Welcome to part 3 of malignancies of the reproductive tract. There are 12 slides to cover in this part of the lecture. So we're going to address cervical cancer. Briefly put the lecture on pause so you can read all the information within the cloud on this cancer quick facts. Because this is what cervical cancer is in a nutshell. When we look at cervical cancer, the human papillomavirus, abbreviated HPV, is strongly implicated. There are a number of strains that have high malignant potential. The HPV type 16 and 18 are the most common cervical cancer-causing viruses. But then we also have type 31, 33, 45, 52, and 58. They not only cause cervical cancer, but they can cause vulvar, vaginal, and anal cancers. And then HPV type 16 causes penile and oropharyngeal cancers. I know you can't see all of the writing on this slide about HPV that's up on the top right. But you can go online and you can Google human papillomavirus images and you'll get a better view of what this is. And this is just the cycle of how the virus enters the body and how it causes cellular changes within the cervix. So when you look at all of these types, type 16 is pretty nasty. Our role is to try and promote the use of vaccines to prevent cervical cancer. We are now on the third generation of the HPV vaccine. We initially had Gardasil, then we went to Cervarix, and now we have the Gardasil 9. So what is your role in preventing cervical cancer? Well, first of all, promote pap smears. You have girlfriends, you have wives, you have mothers, they still need to go in and get pap smears because the highest chance of dying from cervical cancer comes from not going in and getting the pap smear. We want to promote vaccination against HPV. We're still only giving it to girls between age 9 and 26. And we want to educate our patients about reducing risk factors. What HPV strains are protected, or which of the vaccines protects you against which strains? That's a better question. And so you can see that the Gardasil, which was the initial vaccine, protects against HPV 6, 11, 16, and 18. So we got that guy, number 16. We're going against him. Number 18, also implicated. And the Gardasil is for males and females. Now we have the Gardasil 9, and this is designed to protect against new infections, which include number 6, 11, there's number 16 and 18 again, but then also those other ones that can cause the vulvar, vaginal type cancers, so 31, 33, 45, etc. This also is for females and males. Now the Cervarix is for HPV 16 and 18 only, and it is only for females. When we give the HPV vaccine, we're talking a lot about this, don't you think? I think you really need to know this, okay? Because this is what you need to be teaching your patients. So HPV vaccine is given as a 3-dose series. So we give it the first one when they're in the office for the first time and we're discussing it. We give the second dose 1 to 2 months later, and then the third dose, we give it 6 months after the first dose. So it's very similar to when we're giving the hepatitis B vaccines. And this is an IM injection. So what are the risk factors for cervical cancer? Well, age at first intercourse, the number of sexual partners, How many STDs has this person had? Because all of this is trauma to the cervix and a lot of different antigens that the cervical tissue is exposed to. Smoking is highly implicated as a risk factor for cervical cancer. Now, it's unusual to me that having had more than 3 pregnancies increases your risk for for cervical cancer. But when you think about it, when you go through labor, that's very traumatic to the cervix. Another risk factor is if a person becomes pregnant prior to the age of 17. These women are twice as likely to develop cervical cancer. And then other things include a strong family history of the cervical cancer and then DES exposure. Now, I mentioned DES exposure in week 1. You probably forgot about it, but we used to give that to women to prevent miscarriage. Unfortunately, it caused cervical, vaginal, and vulvar cancers in the offspring. So, do we have signs and symptoms? Yes, we do. Do we have medical management? Yes, we do. And we're going to talk about each one of these. And then the nursing interventions in terms of assisting with medical management and making sure that you are protected. So we'll start with the signs and symptoms. Usually, it's asymptomatic until advanced disease is present. And this is where I feel that we as nurses and physicians and nurse practitioners are failing to do our job when we have a patient who comes in with advanced cervical cancer. So what they'll complain about is bleeding out of cycle. And oftentimes this bleeding is accompanied by painful intercourse. She may complain of an unusual vaginal discharge that has an odor, because cancer has a certain odor to it, and it may have an odor of dead tissue. So when we have these changes, well, first of all, we're going to be doing a pelvic exam no matter what. What will happen is we put in the speculum and we inspect the cervix. It's not easy to see lesions when they're small, but when it's advanced disease, it doesn't look good. It's enlarged, it's bloody, maybe black because of necrotic tissue. So what we'll do is insert the speculum and of course do a pap smear. For diagnostic evaluation, we will do a colposcopic exam. And during that exam, what we're doing is using a microscope that stays on the outside of the body, but it focuses on the cervix. So the physician is going to have you set that up. You need to also set up a bottle of acetic acid, which is basically vinegar. And what we do is we brush it on the cervix and then look through the colposcope for abnormal tissue. And the abnormal tissue will turn white, and it starts looking like mosaic tile with more advanced cellular changes. And when we're looking and we see these type of changes, we use an instrument to do a variety of punch biopsies. And that's what's demonstrated in the picture on the bottom left. It feels like a pinch, and when we touch the cervix, there's cramping, and that's about all your patient is going to be feeling. So these are some of the things that you're going to want to teach them about. The physician may ask for what they call scopettes, and those are very long, giant Q-tips. That's what you're looking for. So it's got a cotton tip at the end, and it's got a big bulb, and we use that to stop the bleeding. We also use that to paint the vinegar on it. So once we get our diagnosis, then the physician has to decide on how we're going to manage it. And it can be managed on an inpatient or an outpatient basis, depending on how bad it is, sometimes depending on the insurance, and sometimes depending on what kind of a facility you're in, where in America? Are you in a small little rural place that isn't keeping up and they don't have advanced equipment? We're going to do the old-fashioned way. We're going to take them to the OR and we're going to do a cold knife cone biopsy if the biopsies come back with CIN, because we have CIN1, so that's cervical intraepithelial neoplasm, grade 1, grade 2, grade 3. And a grade 3, what we need to do is a cone biopsy, which is both further diagnostic and maybe full treatment. So look at the pictures here. Outpatient-wise, we do what we call a LEAP procedure, and that stands for a loop electrosurgical excision procedure. So using heat and laser, they use a probe and they can literally just scoop out the tissue. So it does a fine little cut, burns the tissue so that there isn't excessive bleeding, and then the physician is going to hand you whatever piece of tissue that has been excised. They'll hand it to you, you put it in formalin, and then you're responsible for labeling it and sending it off to the lab. Now, if somebody has CIN1 or CIN2, then what they'll do is what we call cryotherapy. And it's similar to if you've ever had a wart burned off or some kind of a skin lesion that, the physician said, this is looking kind of funky, let's freeze it. And what we're doing is we are going to freeze the cervix. And so there's a variety of probes that you need to lay out. And then we have liquid nitrogen, and that's what it attaches to. And we apply it to the cervix. And it is literally freezing the tissue. We know it's done when we can see that the area of the cervix that is just extending beyond the probe itself is frosty. The patient will be complaining of cramping as this is being done. And then if you look at the lower right picture, this is what we call the cold knife cone. And so what they're going to do is the cryotherapy, where they're going to freeze the cervix, but then they use scalpel to excise it. So this one is done in the OR. Cryotherapy and LEAP is done in an outpatient office. So when you're assisting with a LEAP procedure in an outpatient basis, you need to do some pre-LEAP teaching. Discuss the need for an NSAID. Take an hour beforehand to reduce the discomfort. Afterwards, and this is for the LEAP as well as the cryotherapy that's done in the office, the patient needs to be on pelvic rest for at least 3 to 4 weeks after the procedure. And so what we want to do is you have to tell them no tampons, no intercourse, because what will happen is the LEAP, it heals pretty easy, but we still have dead tissue that needs to slough. When we do cryotherapy, it's going to take at least 24 hours until this tissue that we froze to death, literally, starts sloughing. And they're going to have a watery, a little bit smelly discharge for a week or two. And so we want to encourage them to wear panty liners or a Kotex. But you want to warn them that this is normal and expected, okay? And a word of caution to you, if you are assisting in a LEAP procedure, protect yourself. As we use the LEAP, the virus is actually vaporized into the air and it seeds itself on your tissue. So wear a gown, gloves, and a mask. And I have personal experience where the medical assistants in my office actually got the HPV virus on their hands and their arms from assisting with the LEAP procedure. I also know a physician who developed stage 4 tonsil cancer from inhaling the vaporized HPV virus while treating a patient with the Lee procedure, and this is before we even knew it became airborne, so protect yourself. The gown is sort of so-so. If you have short sleeves, wear a gown. If you have long sleeves, you're probably fine. So what are the nursing interventions? Education. We need to talk to them about the need for follow-up. The physician will decide on when they need to come back for a repeat PAP, and it's going to be several months. There's no need for them to come back for repeat PAP smears, especially if it's SIN 1, SIN 2, even SIN 3. And I call SIN, I'm talking about CIN, okay? You want to talk to them about potential signs and symptoms of infection, pain, the discharge afterwards. Reduce risk factors to prevent cervical cancer. You can get it more than once. We can freeze it off, but if you have HPV and you have an unhealthy lifestyle, it can come back. So stop smoking, use condoms, and limit the number of partners. So this ends the section on cervical cancer.